Okay, hello everyone. We are just now getting started. We've got a good number of people joining us, so I'm glad y'all are here. I feel like it's been a bunch of weeks since we had a webinar, but really it's only been like 3 weeks, so hasn't been too long. Um, I am I am going to go over a few housekeeping items. So we use Zoom Webinar, which gives us the convenience of the Q&A box. So during tonight's presentation, when you have questions, I would love if you would put your questions in the Q&A box. It's not the same as the chat box. The Q&A box helps me keep things straight so that I can mark things off as we get them answered. And then if you have any comments that you want to share with the rest of the class or any technical issues, you can put those in the chat. And we will get all of the questions answered toward the end for sure. The other cool thing about Zoom Webinar is you've got this cool reactions button. So during tonight's presentation, you can send up some reactions if you are enjoying what you're hearing, and that just kind of spurs us on to keep going. So I do encourage you to do that. And we've got a good number of people on right now. This is exciting. Okay, so I am going to introduce our sponsor, and then I'm going to let her take over introductions and things for Dr. Morse. While the presentation is going on, my camera will be off and my microphone will be muted, and that is so that nobody gets distracted looking at my beautiful face or hearing my dog bark all night. So ToeFX is a new sponsor of podiatrymeetings.com. They just started, we did a few things together in 2025, and then they joined me as a full-time sponsor for 2026. So I'm really excited to have them. I always like working with people who brought a product to market and are so intricately involved in it. And so that's why I like working with Dr. Irit Van-Ham, because she came up with the idea for this. She's co-founder of the company ToeFX. They provide safe, effective solutions for onychomycosis that actually work. They have the clear toe therapy light. So she's going to talk a little bit more about that. And I know they're usually out on the road at different shows. So what is your next show that you guys have coming up?
We have couple. In April, I'm going to Maryland for 1 day. And then we have Ohio show, and we have the South Carolina, Hilton Head. So busy year.
Yeah, that's exciting. Hilton Head is right in my neighborhood. Well,
Oh,
not really.
okay.
It's like 2 hours from me, but
Oh,
all right. So again, if you have questions, please put those into the Q&A box, and any messages for everybody else or technical issues, you can put those in the chat. And with that, I'm going to turn it over to Dr. Irit Van-Ham to introduce tonight's webinar and our speaker.
okay. Thanks, Anne. So, welcome everybody. I'm very excited to have Dr. Joel Morse today. I know Dr. Morse for, I think, a couple of years now, and actually more. And the first time that we met was in the Derm Food conference. I was super impressed, and I'm very delighted, Dr. Morse, to have you today. It's a dream that came true. So just a short introduction to those who do not know Dr. Morse. So Dr. Morse is a podiatrist in Washington, D.C. He's a pediatric surgeon with more than 30 years of clinical and academic experience, board certified in podiatry surgery and podiatry orthopedic and primary podiatry medicine. He serves on the staff of multiple hospitals, including Sibley Memorial Hospital and Star Washington Hospital Center. Dr. Morse was the president of the American Society of Foot and Ankle Dermatology and was the chief educational chair of the Cherry Blossom and Derm Foot Seminar from 2005 to 2023. Wow. He published and lectured extensively on dermatologic condition of the foot and nail. He is the president of the District Columbia Podiatry Medicine Medical Association. Again, a pleasure to have you today.
Thank you.
Before we jump into the presentation, I just wanted to introduce you also to ToeFX. It will be short.
Well, can I interrupt you? I forgot the most fun thing that we're doing tonight. I'm really sorry.
Sure.
I'm like totally off my game. So if you've been on one of my webinars, you know that I do this kind of icebreaker thing, and I always love to catch my speakers off guard by doing it. So, Dr. Morse, here is a question for you. There's so many good ones. It's hard to choose one. Um,
Actually, I
what?
was happy that you skipped it. I said, yeah.
Oh, no, no, you don't get off that easy. What is a movie quote you use far too often?
Oh my God. Well, fr- I hate to say this, but this is something that's in my head. In Young Frankenstein, when they first come upon the door, no, well, I guess, um, I don't know. That's not the one I want to talk about. Um, um, I don't have the one in my head anymore. I'm sorry. That's all
That's
right.
okay. I know what it's like to be put on the spot. So
Yeah.
one that I say all the time, and I don't actually can't even remember what movie it came from, is negative Ghost Rider. The pattern is full. I feel like it's probably like a Star Wars or something, but I honestly have no clue, but I say it all the time. All
Yeah.
right, Irit, you did not get off easy. What's your go-to random fact that you pull out when conversations get awkward?
Hmm.
Hmm.
Um, so I don't tend to do that, but some interesting topics that I like to talk, it depends on the person behind in front of me. So, like, what's the next amazing trip that they are planning to do? Um,
Oh, that's a good one.
yeah. So
That's a good
actually, we
one.
had such a conversation on the in the conference. So people said a few things, and one person said that he was in Kenya lately.
Oh, that's exciting.
Yes.
All right. Well, I'm sorry for the interruption, but now you can present your information.
Okay. It's like desensitization. Next time we'll do it, it will be so much easier. Next time, can we send ask you a question also?
No, because I'll never stop talking and we'll never get to the actually good stuff.
Sure. Okay. So again, welcome everybody. Let me just start my slides here. So I wanted just to introduce you to ToeFX briefly. We are the host of today's webinar. So we are a complete end-to-end business unit for the treatment of onychomycosis, and I'm saying that because we started by developing light therapy for onychomycosis. It's actually photodisinfection, but lately we are also have a very sensitive and good PCR, and I think this will be the main subject that we are Dr. Morris is going to discuss today, diagnostics. And I think it's something that's very close to my heart. I think it's something very, um, it should be part of the whole treatment. So we offer that, and we're working on disinfectant chamber for shoes and other surprises. So this is our device. It's a dual wavelength light. It's a dual wavelength light, red and blue, 660 nanometers and blue at 410. It's not a laser. The mode of action is different. Um, um, so the mode of action is creating reactive oxygen, ROS, basically by combining a light with a formula. So you file down the nails, you can see here some before and after, apply the serum, it binds predominantly to the infection, and once you shine the light, it's taking ambient regular oxygen that it's surrounding every healthy tissue, and it's also around the fungus and convert it to reactive oxygen, and it oxidizes the cell and it's um, die. This is just to show you how good the affinity of the dye to the fungus. So this is confirmed onychomycosis case, and this is 2 weeks later, so you can see that the dye marked down the infection because it's adheres so well. So you can use it. It has two purposes: one, to withdraw the energy of the light to the fungus, and second, to mark the infection. This is a very exciting time. We got accepted to the Journal of the APMA actually a few months ago, and it's going to be published in a few days in the March journal. So we looked at 165 nails, severe cases, 92% were severe cases, and the efficacy is 73%. This study took us 3 years to complete. So, and without further ado, I wanted to give the podium to Dr. Morse. I will stop sharing my presentation. So, Joel, the floor is yours.
Okay, fantastic. So let me share my screen and I will go like so. Okay, so objective. So hello, everybody. So I'm going to review common nail disorders that we see every day, except for ingrown toenails, as we all know how to diagnose and treat them. While we can still see squamous cell carcinoma, glomus tumor, amelanotic melanoma, and nail unit melanoma, they are very few and far in between. So basically, we're going to talk about dystrophic nails. Um, I do get a lot of my information from these journals, and there is a website named Athens that hospitals pay for. And if you are on staff, you can use it. And I have even set up a program with the help of the library staff that allows me to get all the articles on nail pathology to me every day to keep me informed. I get probably about 16 every day, and half of them are in another language. So that helps me to either uh, to only look at the ones in English. So I I usually have these, or is what I see a lot over the day, and they stump me in that it's not an easy diagnosis. So I'm going to review a series of dystrophic nails and then talk about my approach to treatment of nail pathology. So when you see a dystrophic nail, you ask yourself, is this fungal, ischemic, traumatic, inflammatory? It's hard to know in that it overlaps a lot. You have to also remember the red flags for the malignancy: single unit dystrophy, a non-healing ingrown toenail. How many times do we see that somebody has come from another doctor with ingrown nail, that's something that you should put in the back of your head. Atypical pigmentation, persistent granulation tissue, and a nail that doesn't look right. So whenever we see that, you want to think about the unusual ones, but mostly we see the regular ones um, like this. So, picture number one, this is a discolored nail on the fibular aspect. It's possible the distal lateral onychomycosis. We have a shortened nail. There's extra skin in the front, so this is also the disappearing nail bed, which could be due to trauma or onychomycosis. We have a long second toenail, so sometimes these flap over on the fibular aspect, so it could be irritation. We have seen a lot of patients wear compression hose, and a 20 to 30 millimeter hose can really tighten the feet or the toes on top of one another. We see on the third toe dermatocytoma, so it kind of points you in the direction of a onychomycosis. This is a individual who most likely doesn't take care of his foot, dry skin. Hallux has incurvated now immediately with a band, 45 millimeter dark band laterally, may be due to pigmented onychomycosis, blood, or melanin. No Hutchinson sign or pseudo Hutchinson sign. There is a mild bunion, so you could have that overlapping issue. We have these uh, web toes, so probably not. The next one, this is a yellow nail with loss of nail plate. So disappearing nail bed, and we see that the plantar skin from the tip of the toe has overtaken the nail bed. We have that bulbous tip, which may be due to the disappearing nail bed, but there may be a subungual exostosis under there. We do have hair on the toes, so good perfusion. Sometimes lack of perfusion or PVD will give rise to dystrophic nails, in that the nails need a lot of oxygen, and PVD, lack of oxygen. Um, in this one, the individual should have had the polish removed from the other nail so that we could see if it's more than one dystrophic nail. Um, so this is what we see every day, right? Involvement of all five nails with the dystrophy. Um, um, Usually with onychomycosis, my average is 3 nails per foot. So this is a little unusual. Um, we see these angular nail abnormalities. When I have a bunion and hammer toe, it's not unusual that the nail will adjust to the angle of the toe where the weight is. So we see that. So that's more of a biomechanical type of an issue. The hallux nail shows onycholysis. There's no hair growth. So again, dystrophy could be due to PVD. Um, and we see, as you know, when you have absent pulses, hair loss issues, cool skin, always think about PVD in the back of your mind. So
Dr.
let's,
Morse, I have a question here.
sure.
So, I guess, could you conclude also here that you see onychomycosis? Because I see dermatophytoma at, I think, the last toe or in between.
E- yes, I would say that this has a very strong um, 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 evaluation that there is onychomycosis there, although there is an overlap in that you may have uh, psoriasis as well. You could have PVD as well. However, as usually, the exam, KOH, PAS, um, those tests are usually used initially to help move you in the right direction rather than just saying that it is onychomycosis. Um, okay, and this one, this is another one. So in this one, we have, if you don't see it, swelling of the proximal nail fold. It's not smooth there. The nails are yellow and very long. So sometimes when I see two nails that are bilateral and look the same, I usually would think of a shoe gear issue. Shoe is either too long or too small. The patient is wearing a tight sock, something like that. And this is what we see a lot. Single nail that is abnormal. It's 5 millimeters thick. We have again disappearing nail bed, single nail dystrophy, no hair growth, maybe PVD. Uh, the the um, uh, the PVD can result in an abnormal, a layered type of the keratin. So even though this could be onychomycosis, if you do your PAS, PCR, and you don't get anything, then you know that it may be either trauma or the PVD. So I like to start with this. So we all see lots of ingrown toenails. Um, and right now, we're not going to really review ingrown toenails and the treatment. However, a lot of nail pathology, including ingrown toenails, may have a biomechanical component. And so in your office, even when you're wearing the derm hat, you can also do a biomechanical workup and see if AB and orthotic with a Kirby Sky would help the patient and resolve the nail issue biomechanically rather than straight dermatology wise. Nail pathology does not have to be in a vacuum. So, what we see ingrown toenail lookalikes, pyogenic granuloma, retronychia, disappearing nail bed, onychomycosis, nail psoriasis, glomus tumor, subungual ecdysostosis, and nail unit melanoma. So, this is a patient who had swelling in the posterior nail fold, 6 months, nail not growing in length. Internist had the patient on 2 antibiotics, no resolution, erythema and pain. One. This is the second one. Patient with a triple layer nail plate and a stacked layering of the nail. Slight yellow discoloration, had worn tight ballet flats. So I view each of these as having a nail bed that does not attach nail, and this causes the matrix to produce more nail, and that is what gets you the stacked appearance under the nail for the first photograph and along the nail bed or the other one. So retronychia. Now, this is something that we see a lot. Sometimes we get wrapped up and we think it may be a paronychia infection. Um, I view this a lot, and we we tend to see that proximal nail swelling, and in many individuals, they have five, six, seven stacked nails, almost look like a seashell in a way. Um, um, One of the issues is lack of nail growth. And so somebody may say that they haven't cut their nail in a while, and that then is a clue that something such as retronychia is happening. A lot of the time, it is what they're wearing. Sometimes it is if they have a hallux hammer toe and they are propulsing off of the toe that traumatizes the nail, and they get a um a retronychia that way. Above all, if you have it already, proximal nail avulsion is really the way that we resolve this. You can try a larger shoe, but if they already have the swelling and they have two, maybe three nails under the nail fold, you have to remove the nail plate. And Chris Adigan, who is in the Nail Council and very well known in nail, had done this a really good commentary on retronychia. So if you ever want, this is an excellent place, Dermatology Online Journal, and you can go there even right now and look it up. I will just want to say a shout out. Over the years, I have run meetings with Cherry Blossom, which turned into the Dirtfoot. And these are some of the many individuals who have passed in front of me over the years of the meetings, and all of them have been involved in nail pathology. So look for these people. They are still uh, around, and they have excellent papers that are out there. And hopefully one day we'll have another cherry blossom or dermfoot seminar. Counts full nail disorders. These are two podiatrists who have been the podiatric anchors in this association. And it's open to both podiatrists and derms. And so look for the Council for Nail Disorders. They have a lot of excellent events going on. So this is the other type of a look-alike for ingrown toenails. It is a distal problem, whereas the retronychia is a proximal problem. Um, this can result in a bulbous, red appearing tip of the toe. The distal bulge can look like the toe is inflamed and infected and give the impression of an ingrown nail. However, we know that it is not. This is the landmark paper if you are into derm. See Ralph Daniel. He wrote the paper and he explained exactly what it was we were looking at. He and Dr. Scher, who just passed away, had written a book called Nails, and in it they explain exactly what is going on. And he basically explains that it is a injury to the bed, and usually it does not return. It is permanently shortened nail plate, and it's due to a lot of issues, um, and they are listed here. He did a follow-up study, and he noticed that it's more common in older individuals. I guess that as the nail bed loses some of its vascular ingrowth, you get um, this point of no return. Um, and this may be one of the reasons I recommend that they treat their onychomycosis, if that is the cause, in that nobody likes to have an exposed tip of the toe, and that may irritate the toe even more. So I am very interested in articles. I came across this article, and um, this is an article that was trying to find a solution to this disappearing nail bed. And in the article, they had recommended that one use what's called a new taping method, a topical solution called onogen, which is really milk protein, and that's supposed to be the fertilizer for the bed, and a nail straightener to help uh, guide the nail as if it were on a railroad track. And this is a very interesting paper. Eckhart Haneke, originally years ago, 30 years ago, talked about taping methods. And this is something that is used. I recommend you all have a look at it, in that it is a very interesting. I would like to just say one thing. Um, I use a lot of avulsion in my treatment for retronychia and disappearing nail bed. And I have gotten myself into hot water by not making my consent exact enough. I, I usually you want to tell the patient that this is not just a routine nail avulsion. We are intervening in a nail unit that is already structurally altered, and outcomes are inherently unpredictable. So you have a pre-existing pathology. We talk about the purpose of the procedure and the uncertainty of regrowth and cosmetic outcomes. So I have over the years redone my consent for these procedures, and that has been very helpful in averting a lot of problems along the way. So go on to the next. So we come to the gorilla in the room, onychomycosis. So as we know, the most common dermatophytes, the most common probably 70, 80, 90%, depending on what paper you read. T. rubrum, yes, that is the most common. And this is what we see a lot. A nail that is very thick. This patient has two nails involved instead of the three that is, I think, the average. However, let me stop right there. You know, everybody knows this phrase that 50% of the time fungal nails are not fungal. So this is the paper, and Dr. Richard Scher was involved in this. And this was the one that put it on the map that if you're not doing a culture or PAS or GMS or the PCR, that you may be trying to resolve a fungal condition from something that is not a fungal condition. So this is a great paper that you may want to reference. And the other thing that I use a lot is this onychomycosis severity index. There is also a psoriasis severity index, but this one, and this is the landmark paper, Antonella Tozzi. This is the top people, Ralph Daniel, Richard Scher, Phoebe Rich, Bonnie Lusky. These are the people who put nails on the map. And in this one, it's an objective way that you can use in your own office that will look at each of the nails individually and track the response. Yes, it takes a lot of time, although it really lets the patient understand that not all of the nails are the same to start with. So in this case, they take the nail involvement, how much is involved, and the distance from the matrix, and that closest to the matrix is harder to resolve. And then they take area score, time proximity score, and 10 if there is a dermatophytoma, very hard to resolve, or hyperkeratosis, usually more than more than 2 millimeters. And then you get a number, and 35 is the highest number, but 5 times 5, if you have a involved nail like the nail that we just had a look at on that other photograph, is 25. 25 is a severe nail. And so you can relate that to the patient so that they understand that this is not a drop in the bucket. And sometimes we do not get results. Um, OSI helps expectations. I once talked a lot about patient expectations, and the doctor can really um, explain it as long as they have the papers with them. And everybody knows about clinical cure versus mycologic. And if you put them both together, complete cure. So, onychomycosis, you can read the slide. That usually laboratory confirmation is required in my book. If you don't, then sometimes you are doing a disservice to the patient. It costs a little bit more money, I admit, although this way you're treating the patient correctly. So Gupta. So Dr. Gupta is synonymous with onychomycosis. He has written many articles, hundreds of articles on onychomycosis, and if you are ever interested, you can Google his name. So his this paper says terbinafine and itraconazole are the best. There was an earlier paper in 1990 that was the line study, Lamisil, itraconazole treating onychomycosis, and that was a landmark paper that showed how terbinafine hits organisms 80% of the time, itraconazole 70% of the time, still very good, and those put them on the map. There are other ways, the topical, the Jublia, the Tavaborol. Those are ones that are out there. I know that he says that he uses topical only when the nail does not involve the matrix, when it's less than 50% involved, when there are 4 or fewer nails, and when there is no subungual uh, then there's less than 2 millimeters of the subungual keratosis. So that's from Dr. Gupta. So as you know, there is combination therapy, uh, this mechanical debridement. I know that there are a lot of docs out there who, um, because of the grinding and the vacuum, they don't do that. I have very good vacuums in my unit and on top of me, and I wear a mask and I grind in that. I do think that it increases the cure rate. So now we move to emerging therapies. So these have been out a while. The laser therapy, mechanical reduction. There were some that they put little holes in the nails to increase the surface area. That didn't really lead anywhere. And photodynamic therapy, which is what we talked about earlier. Usually, in a lot of older individuals, they may have other things going on, drug to drug interactions. They may have um, hepato, liver problems already, and the oral medications are not open to them. And so that these other ways are out there, and I think you should look into them. There is a microwave unit out there as well that is the one used on the warts, and they are doing studies right now as well to see if there's anything there. However, the photodynamic is out there. They have a lot of studies, not only their own, but there are a lot of studies out there. I just go back to Dr. Gupta that this is another one that put terbinafine and itraconazole on the map. Excellent medications, although, you know what? You do have lots of drug to drug interactions. And whenever I use these meds, I just have a little app that I plug these medications into with the meds that they're on and make sure that I'm not hurting the patient by not understanding that the itraconazole, it has a black box warning with those who have heart failure issues and whatnot. So we come to how we make the diagnosis. So KOH was yesteryear. Now we do PES, GMS, FM. So the melanin, the PCR is very exact. The fungal, if somebody can't afford a PCR, then fungal culture is available, but we get a lot of false negatives. False positives and dermoscopy. So dermoscopy is something that I think everybody should have in their office, just like all of the other devices we use to help make the diagnosis. And Antonella has this excellent article, which is out there. And this is just an image of a nail. And we can see in the center this kind of spiked area. And that is one of the four key dermoscopic uh, signs that are out there. And so sometimes if you can do a PCR, at least evaluate it with a dermatoscope and see if you can see any of these. So the original treatment was always topical, oral, or oral and the debridement. And the last one that's not on here is avulsion. So I avulse a lot of toenails. The one problem with it is if you avulse nails in an older individual, they have a nail bed that is very weak, and you may take off the nail not knowing that you're taking off the nail bed and you're looking at the bone. So that's problematic. And so sometimes in older individuals, think about the mechanical nail reduction and uh, the photo um, uh, excuse me, the 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 photodynamic therapy. Sorry. And avulsion, you can also use taping with that to kind of organize it so that the nail grows straight and doesn't have to go over the distal bulb at the end of the toe. So Irit already talked about the photodynamic therapy and the way that it activates a reactive oxygen, and this then results in a lysis of the cells. What's nice about this is that it doesn't really matter if it's a dermatophyte, saprophyte, or yeast. They all have a fungal wall, and so we don't really have that issue with sometimes we put the patient on terbinafine, but the patient has candida, or the patient, sorry, has a saprophyte like aspergillus, and it doesn't work. This averts all of that. They just have to have the diagnosis of a fungus. There's a lot of studies out there from maybe 20 years ago, and then there are the newer studies that Irit had reviewed, and the advantages are no systemic toxicity, no drug to drug. It is an easier approach for the older patient. Yes, they have to come in every 2 weeks for 6 months or 5 months, but at, at least you have a an issue where you're not hurting the patient in trying to resolve this issue. Um, and I reviewed all of this already. It helps to take the thickness of the nail down. Um, I have one case in here. This is an individual who had this really involved toenail. It wasn't resolving with some of the topical medication. She wouldn't go on oral medication. And by the third application, I did not have any um, awareness that the fungus was still there. We still see that there's this amount at the end, which still shows me that there is still fungus in the nail because it is attached to that area. But other things that we see, traumatic nail disorders that can look like ingrown toenails. This is one we see a lot, subungual uh, under the nail. Sometimes with this, if we see it, we make a hole in the posterior nail plate and see if we can evacuate it out. Sometimes it is organized and we can't see it. This is not always a traumatic nail. This could be, squamous cell carcinoma, but you're not really seeing it. So this should work its way out a millimeter a month. If it's not, remove the nail and do a biopsy right in the matrix or in the bed. So we talked about this in a way. This is an injury that happened, and the nail has lifted up. So more of a traumatic problem, but it could be a secondary fungal infection, or it could be psoriasis or lichen planus. Onycholysis, this is what we see that leads to disappearing nail bed. It can be due to a lot of things. There's a lot on that topic. A lot more journals are out there. So melanechia, brown or black pigmentation. We see this a lot in Asians, Hispanics, African Americans. When you see it on a lot of nails, it's usually melanocytic activation, and it is not the worrisome one. Usually, I have seen this on all the nails, and I've only seen the melanocytic proliferation on hallux toenails. So I don't know if anybody has ever had a melanoma of a lesser toenail, but in the literature, it really doesn't exist. Even in the hand, I think the thumb is really when we see that. Um, um,
Dr. Morse, can
yeah,
we? I see that we have so many questions.
sure, sure. Why don't we stop
Um,
there?
so if you want to maybe wrap up or
Okay,
stop now
okay,
for.
sure, I can wrap up. So we go on. This may be a traumatic nail, maybe a ethnic nail. This is a proliferation. So the red flag. So anytime you don't see what you think you should see, then you need to do a biopsy. And if you're afraid of biopsy, then at the very least, get a dermatoscope, uh, and you can evaluate what you're looking at, perhaps confer with a colleague of yours. Tumors of the nail unit, we see this very infrequently, but keep it in the back of your mind. I've never really had any patient in with any of these pigmentation issues. We see this, yes, a lot ingrown toenails, autoimmune. We see a lot psoriasis, lichen planus. The psoriasis is usually a clinical diagnosis, where lichen planus is usually a punch biopsy diagnosis. And there's the clinical and when to biopsy when you cannot explain what you're looking at. Okay, thank you.
Thank you.
Okay, stop my share and we'll go back.
All right. That was amazing. And I'll have to run some reports, but it might be like record attendance tonight. So I'm excited to run those reports. We'll see. So we do have lots of questions. If you haven't typed your questions into the Q&A box, I encourage you to do it there. Um, Irit, do you want to read these questions or would you like me to read them?
Yeah, if you can read them,
Sure.
that would be
Okay,
excellent.
so I'm going to start at the top. What is the app to see contraindications with orals?
Yes, so the app I use is called is called Pharmacist. Pharmacist. It has a big R and an X, and it costs maybe $100 a year or $100 for a couple of years, and they have an excellent way to write in all the medications, and it will help to um, let you know what you're looking at. There are a lot of the EHRs nowadays that that when you write in a medication, it may, tell you that there's a drug to drug interaction. Although don't rely on the EHR. Always use another a real app.
All right. Hasn't it been shown that nail avulsion usually results in the new nail coming in just as fungal as the old nail?
Well, you avulse the nail in order to lower the fungal load, but you have to treat the fungus. So avulsion helps you out, but it's not the main approach. Either put the jublia on the nail bed, photo, use photodynamic to help kill the fungus off, use oral medication. So avulsion that's not the treatment. It helps in the treatment.
All right. Is phototherapy effective in both dermatophyte and not dermatophytes onychomycosis?
I will let you answer that.
Yes, it does. So, as Dr. Morse said really nicely, the mode of action is creating reactive oxygen. So, any cells that has a specific membrane like yeast, mold, dermatophytes, it doesn't matter, bacteria, it will destroy it. And it's very specific to pathogens because the serum, the blue dye, adheres mainly to cells that divide rapidly. So yes, it doesn't matter. It's not only for dermatophytes. Although dermatophytes are the most common cause of onychomycosis.
All right, super. What are your thoughts on treating onychomycosis in a pediatric patient who has had severe dystrophic nails since birth?
Well, I would always run the culture or run a PCR, PS, and really understand that it really is a fungus. I have no issue with putting a young patient on terbinafine. There are lots of studies out there that use a fourth of the adult amount or a third of the adult amount. I talk to pediatricians all the time about this, and I don't think that you'll um, have a problem with that. I have avulsed nails from youngsters, but of course that is not a fun day, but it lowers the fungal load. Um, but oral medication is what I've been using. I haven't used any photodynamic on a young individual, although I think if we talk to the parents, I think as a parent myself, I could think that I would rather do photodynamic. It makes so much sense, and it's less invasive. And so I don't know. Have you used it on young individuals,
Yeah,
pediatric patients?
yeah, not
Yeah.
yeah. There are few clinicians that used it on children.
Yeah. Good. Well, that's my next one.
Yes.
All right. What do you think of compound topical medications for onychomycosis?
You mean compound? Is there a explanation? I mean, I know that there are a lot of ones that are not FDA approved. The only two FDA approved or the tavoboral and the efinaconazole. So I usually try to use the ones where there are papers out there. However, I think as long as you debride the nail as thin as possible, then I think that the other ones can help you to achieve that. But again, um, I like the topicals that have been um, evaluated via papers.
I wanted to add that the only maybe advantage, but I don't think that it's possible to do if you go to a pharmacy that can do compound,
Oh,
and this is I think what's so compounding, and they can mix few active ingredients because sometimes it's not only dermatophytes. For example, it can be dermatophytes with candida, so that can potentially be more effective.
right, right. I know that there are ones who will add in some oral medication into a topical and shake it up, but I've never really understood how that helps. But I guess that is something to look into.
Uh, do you recommend PAS or PCR testing?
So I mean, the issue with the PCR is that it can be expensive, and you can make a happy patient very angry at you if you don't explain that to them. So usually PAS is an excellent, excellent test, and that will let you know yay or nay whether they have mycotic nail infection. And you know that 80%, 85% of the time it is a dermatophyte. So I would use the PAS initially, and if the insurance allows it, do the PCR so that you're, you're right on cue. Because if you have a saprophyte, then you're not going to get results with your terbinafine.
All right. And one of the questions that came into the chat is related to that. How much does a PAS cost?
Well, I know that if you use one of the labs that is well known, I've had a price tag of $1,600, um, a lot. And it's real hard to console a patient who has that price tag for that. Now, I know that Irit has a company where the price tag is much less. So I'll let you talk about that.
Yeah, sure. We have developed a very sensitive and cost-effective PCR, I think. PC, PCR, in a way, it's superior to culture, and correct me if I'm wrong by your perspective, and PAS, because it's you are not rely on clinical observation of the technician. It just you take DNA and amplify it in a machine. So we have developed a PCR. It's not it's much cost effective than what's available, because we are looking only at the causing a species for onychomycosis, and also we found a nice way to reduce the price. So happy to provide more information. You can email me.
Great.
So I wanted to add to say about culture and PAS. It's more accurate, but culture is very tricky. A, it's super slow. B, there are sometimes environmental contaminants that eat on the nutrition on the petri dish. So it's super hard to sometimes find to see, for example, dermatophytes, and then the percentage of false negatives is extremely high. It can be up to 70%.
Hmm. Okay. So don't do them.
Yes.
All right. Let's see. Is tea tree oil useful as a natural treatment for onychomycosis after reduction of nail plate thickness?
Or maybe you answered.
Well, I know that I tend to read a ton of articles from Athens that get sent to me, and none of them have tea tree oil in it. So I would say that if the patient can't afford the Jublia or the Tavaborol, then that is a good place to start. Although if it does not work, it does not mean that they don't have a fungus or something. But yeah, I would always try to inform the patient that the two topicals are FDA approved, and there's a reason. I don't know if you know anything more about tea tree oil.
Yeah,
Irit?
I just wanted to say, as a toxicologist, tea tree oil at high concentration, when it's not diluted, can be super risky to the skin. It can cause irritation, an allergy, and also because it's oil, and the pores of the nail is meant to for small molecules to penetrate, such as water, for example, and oil does not penetrate through the nail plate at all whatsoever. So just my 2 cents. And also, it smells like hell.
Um, all right. Earlier you mentioned that you see three nails involved per foot. Is there documentation of this phenomenon?
Yes, and I will go into one of Gupta's papers, and I think that that is an accurate diagnosis. I know that years ago there was a type of a pseudo laser out there that I plucked down $50,000 for, probably not the smartest thing, and it has these four compartments, and you always ask yourself, why doesn't it have 10 for all 10 nails? And the reason was that they did studies and there was usually three nails per foot that had the fungus. That was their study. But yes, I'll be happy to send that on to Anne and she can try to disseminate, but it will be by doc, by Dr. Gupta.
All right, so a couple questions related to ToeFX. What's the active ingredient in the blue serum?
The active ingredient in the blue serum is a photosensitizer. It's methylene blue. But in the serum, there are also few other active ingredients, such as solvents that kills the fungus and help the blue dye to penetrate, and also botanical extract with anti-inflammatory and antifungal properties.
And how long after the photodynamic treatment will patients see the results?
Maybe Dr. Morse can answer, but I
Yeah,
can.
I would say that I mean usually we see the results right away. You see a slow propagation of 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 normal nail. Usually the oral medication, a new nail will push out the old nail. So that takes about a year to see it. Here, it's not the same. I see the results a lot earlier than that. And I know that we have a protocol. My protocol is we have the patient in for 12 sessions, 2 weeks apart, and they have to agree to that. And the ones who are not able, I don't want them as a patient because then we're going to get a result that is not based on the protocol. And so um, I don't know um, how many weeks does it take to see um, new nail?
According to our studies, it's about minimum 2 months, 4 to 6 treatments, because sometimes with those, especially older patients, it's about half a millimeter a month.
Hmm,
Then the growth of the nail is slow. So to see 1 millimeter, it takes about 2 months.
okay, good.
Just before that, it's hard to see.
All right. Is a KOH with microscopy useful in the office setting?
Um, I mean, I have not used a microscope in my office. However, I am friends with a lot of dermatologists, and they still use that KOH, easy to do, and they look at it under the microscope. So I think that if you have a microscope, then that's a perfectly good task to do in your office. However, I think that a lot of us, we would just send it out to a lab.
I wanted to add to this that it's not super easy. It's not super easy to see the hyphae, especially if you don't, if they're not stained with some stain or fluorescence. It's not trivial.
Okay.
Have you seen hyphae under the microscope?
I don't only under a photomicrograph that gets sent to me from a lab, but
Mhm.
no, I don't have that knowledge.
Is there a CPT code for this treatment, the light treatment?
No, there is a code CASH, cash.
Clever.
Yes.
Oh,
So since it's out of pocket, do you have a recommended cost range for the treatment every 2 weeks?
I I I will let you know what I will let you know what I charge. I mean, I charge $150 a a visit, and my staff after the first one, my staff does a lot of it. So 150 times 12 is $1,800. And I mean, um, I usually do all of the nail debridement, and I analyze it right before the patient is in the room.
Yeah, this is the price that we recommend to charge. Yeah.
All right. Dr. Barbara Hirsch says hello, and thank you very much for all your presentations. Um, and moving on to the rest of our questions. What was the success rate like with nail avulsion followed by efinaconazole 10% topical solution in resolving mild to moderate onychomycosis?
Yeah, well, I think that works very well. Um, I don't know. I don't have a scientific study going on. However, in a lot of individuals, they don't want oral medication and they want insurance to pay for their care. So we're left with avulsion. And I it's not unusual that people will want all their, 6 or 7 uh mycotic nails avulsed, and I will do that and then use the topical. So I think it's high. Um, as long as you have done your homework and they don't have saprophyte, because the topicals don't work well on saprophytes. And usually, if a nail is more, I mean, I know that Dr. Gupta has his 50%. If it's 50% or less involved, he thinks the topical will work. I go with 25% or less involved. I am not a strong proponent of using a topical if a nail is 100% involved. Even though I avulse the nail, I don't think it will work.
Do you have any comment on rising evidence of terbinafine resistance and how would you alter oral therapy in that case?
Um, yes, I know there was a recent paper by Dr. Gupta that said that itraconazole is coming back more into vogue because it doesn't have the resistance issues. Um, I know there are labs that will evaluate if you have a organism that has resistance. I haven't seen it. Maybe 1 or 2 times. I get somebody where the medication does not work. Usually it may work on some nails, but not all of the nails. So it's not as prevalent in my office, although if the lab will pay for it, and I mean, if the insurance will pay and it's not an additive for the patient, then knowledge is power. And I would run those tests. I don't know. When you run your PCR, are you evaluating if the organism has um, the um, the markers of resistance?
No, we do not look at mutations. And actually, yeah, Brian Mackinson, I think, has a comment about that for you on the questions. Maybe you want to go to this one, Anne, first?
Sure. You want me to read the comment?
Yes.
Okay. Commenting on terbinafine resistance question. Terbinafine resistance is a non-problem. 17,000 cases from Gupta revealed less than 3% presence of resistant loci in the testing, and he could not say when the presence of the loci actually translates to actual resistance. The sponsor of that study, of course, has not pushed for its publication because they are heavily pushing terbinafine resistance PCR testing. My own study of 9,000 cases showed up to 12% false negative PCR, positive PAS, and negative PCR. At recent CND meeting, no one thought terbinafine resistance was a clinical problem. Experts from all over the globe were unanimous. The ToeFX PCR test may be an eventual affordable test with advantage.
Okay, well, the the man has spoken. And I I value Dr. Markinson's comment. He is the ultimate in the researcher and the lecturer, and I appreciate you listening.
Yes, me too.
All right. Does toenail polish interfere with the photodynamic treatment?
I just wanted to say the nail polish interfere with everything. It's blocking any penetration through the nail. So not only the ToeFX, but also any topical. Also, it's blocking evaporation of humidity from the nail bed and blocking oxygen going in. So overall, it's not so great.
All right. Can you compare Julia and Caradin? Julia is too expensive. Majority of patients can't afford it.
And and what was the question again?
Can you compare Julia and Caradin?
Let me see.
Um, I mean, I know that they are the two FDA approved medications. The Caritin is, I think, Tavaborol. Is that right, Dr. Markinson? Um, I I would I would say that if you're talking about the two FDA approved medications, I think that studies show that they're pretty much the same, but Jublia just has maybe better marketing, maybe better studies. Um, I don't have the answer.
And
All
also,
right.
I wanted to add that both um, overall topical, this is the cure rate is low, and also there is other issues that we are not going to discuss today, but there is problem with compliance with the patient. But you know that I just wanted to mention because they need to apply it once a day.
After you see results of photodynamic therapy after the initial few treatments, can you make appointments further apart? Have you seen better results with using a urea-based topical with photodynamic therapy like tolsilin?
No, so because we tested the protocol every 2 weeks for about 10 to 12 times. When you see a good progress, we recommend to switch to maintenance, where yes, you can spread the treatment every 6 weeks, 6 weeks to 8 weeks until a full resolution. It's not needed to use urea because of the debridement of the nail, and also urea has water content, and it might interfere with the penetration of the serum. So it's not needed.
Dr. Morse, Do you remember the name of the site where you get the articles that the hospitals have links to?
Yes, the site is Athens EduServe. Athens EduServe. So it has PubMed, which is the one from the National Institutes of Health, which is right up the street from where I live, and it has all of um, the other ones that have um, I'm looking for another word. There's researchgate.com. That's another one. Researchgate.com. Sometimes you can fake them out and tell them you're a famous researcher and get yourself in, but that is excellent. You could really find a lot of articles like that. But the library at your hospital, they are oh so willing to help you, and that's how I get these articles sent to me as if I'm somebody important.
You are somebody important.
Do you use pulse dosing or regular dosing?
Well, usually um in a lot of well, the regular dosing is for the terbinafine, and pulse dosing is usually itraconazole. The older the patient, I use Dr. Markinson's approach. I use 1/3 of the normal terbinafine amount, and we get excellent results. I sometimes Dr. Gupta had a graph at one of my seminars, and it explained based upon the type of the saprophyte what he found as the better approach, either pulse dosing or using 200 milligrams a day of the itraconazole. So again, I'll be happy to share that slide from Dr. Gupta. I could send it to Anne. I have it on my telephone and I look at it, throughout the day when I have somebody.
What is your idea on dermatophyte test medium to detect dermatophytes?
Gosh, you know what? I think that came out in prehistoric times when Dr. Markinson was a doctor. So maybe we could ask him.
All right. While we're waiting for a comment, how often do you see Fusarium SP reported on the fungal culture, and how do you treat this?
Well, I mean, I see it. That is through PCR. Um, and it's a saprophyte. It's a hard organism to resolve. It's not unusual that I will review with the patient that I recommend avulsion of the nail. And sometimes I will throw the kitchen sink at that. I would do avulsion, do topical Jublia or topical anything, and put them on a uh, a itraconazole. So, and this is again as I review this in my head, rather than doing all of that, why don't you do photodynamic therapy? That way you don't have to revulse. You don't have to have the increased risk of possible side effects. So there's another avenue. The issue is one is covered by insurance and one is not. And so as a doctor in private practice, that's what we deal with a lot. And sometimes it's hard to um, understand exactly how you're going to go. You don't want insurance to rule you, although sometimes it does.
All right. Um, it looks like we have answered pretty much all of the questions. And that was a lot of questions. So
Yes.
I always like it when it's interactive like that. So thank you to everyone who participated. I am going to send a list of all the questions and the chats to Irit, and her team can review and discuss with Dr. Morse, and they can send out additional information. I did put her email address in the chat, so if you have pricing questions on that device, you can email her and she can give you all that information. And that is our show, folks.
Thank you very
Yeah,
Thank
much.
you.
We
Thank
are
you
appreciate
also
guys
the
for
time.
being
Thank you.
here.
we're
Thanks
also
to our
going to send
sponsor.
the Dr. Morse, Joel Morse email. So if you want to ask him more questions.
Oh, perfect.
Thank you both. Oh, so many hearts and
Yes, I love
thumb
it.
up.
Yes. So thank you, Dr. Morse, for your time. Thank you, Irit, for your sponsorship. And we will see you all next time.
Okay. Appreciate
All
it,
right.
everybody. Thanks for
Appreciate
listening.
it. Have a good
Good
night.
night.
Bye.
Good night.
Bye.